Good morning, everybody. Thank you for your attention. So welcome and welcome and welcome. So my name is Shuk-Mei Ho, the chair of the Environmental Health at the College of Medicine at University of Cincinnati. Today, I'm really, really delighted to see that our next generation of public health practitioners are actually leading this event. The UC MPH students are actually leading and organizing this event with the department support. And we have a very packed program today addressing a very important question, and that is the opioid overdose epidemic, which has taken so many lives, young lives, and it's really important for us to actually talk about this from a multifaceted angle. And in the event of celebrating the National Public Health Week. I won't take up too much time, but to thank the organizing students' body, Gamma Rho members, led by George and Anna. They did umpty hours of work. And also thank our MPH director, Dr. Junying. And basically, without a lot of reading, you already see that we have a very packed program. Actually having, for example, the keynote speaker, Chief Tom Synan, and he's going to give you a very broad stroke pictures of what is happening in this area. And then we also have commissioners from Hamilton County. We have Health County, the Heroin Coalitions leading programs, and we have psychiatry departments, colleagues, and emergency medicine colleagues from both UC and Brightview. And I don't want to read because you can see the program participating in the discussion. And particularly, I want to thank Allison Sampson for mediating the panel discussion later on. And the most important thing is I really want to introduce our next speaker, that is Dr. Neil MacKinnon, our Dean of Pharmacy, and he and also Dr. Melissa DiBello from Psychiatry are leading the UC and UC Health efforts on the opioid task force in the coming years. So I want to just introduce and thank him for coming. Neil.
All right. Well, thank you, Dr. Ho, and this will be really, really short, so don't worry, we're not adding on an extra speaker to the program. I'm excited to be here. Thank you for coming to the College of Pharmacy. So as mentioned, I'm the Dean of the College of Pharmacy, but if I can share a secret with you, before this job, I was in a College of Public Health in the University of Arizona. So I was a department chair for public health policy and management and a center director for rural health. And so I have a real special place in my heart for MPH students. Who's an MPH student here today? All right, so we've got a lot of you, and I know as Dr. Ho already mentioned, this really is a student-organized and student-led event. So, that just shows kind of the power of students and what MPH students can do. As Dr. Ho mentioned, we do have a opioid task force. It's a joint task force between the University of Cincinnati and UC Health. We've kind of been under the radar a little bit our first year, making sure that we're kind of doing things properly and doing things internally before we spread the word externally. But we do have 4 kind of working groups as part of that. And actually, one of those working groups is practice. How do we improve practice and take better care of our patients, everything from prevention to treatment? And actually, Dr. Stuart Wright, who's co-chair of that working group, is here today. We also have a working group that's around research. And we're doing a lot of research related to opioids, both prevention and treatment, finding new strategies as well. We have a third group that's around education. So how do we ensure that all of our health professional students and even other students such as emergency management and criminal justice are working together and have competencies to work with patients that are suffering from this crisis. And finally, we have a group that's related to community outreach as well. And I think we've got a few other, I know Dr. Hayes is here, you're part of this task force. We've got anyone else who's part? Okay, so back in we've got our emergency medicine folks as well. And so around there's about 50 individuals across the whole university and health system that are part of this group. So with that, though, that's kind of, again, we're really excited about this topic, about today's event. I live on the edge of Newtown, so I drive very slowly.
You never got a ticket.
I never got a ticket, all right, so I drive very slowly through Newtown, but
His license plate.
exactly, I'm okay. But really excited about today's speaker. But our last kind of person that is going to introduce our speaker is Josh. Again, this is a student-led event, so please give a warm welcome to Josh as well.
Thank you, Dr. Ho and Dean MacKinnon. I'm Josh Baugh. I'm president of the Delta Omega Gamma Rho chapter here at UC. We are fortunate to be organizing this event. A few little sort of housekeeping items. So there's a live streaming in G19 if there isn't any more room here. Also, this will be streamed online. There's a link on the Dean's List, and it'll be available for viewing after today's program. So I'm going to move on and go ahead and introduce our keynote speaker, Chief Tom Synan. Mr. Synan's wide experience has allowed him to a unique and complex look into the heroin crisis. Becoming a leading advocate, he is a United States Marine Corps veteran and a 24-year police veteran in the Newtown Police Department. For the last 10 years, he has served as a police chief and a SWAT Team Leader. In 2014, Mr. Synan met with others in Hamilton County and helped form the Hamilton County Heroin Coalition. He now sits on the steering committee and is the chair of Interdiction, where he coordinates law enforcement efforts to reduce supply and works with other members to help reduce demand. His work with the coalition has been used in national and international publications and media outlets. Mr. Synan has testified before the U.S. Senate Homeland Security Committee and on synthetic opiates and the impact of fentanyl and carfentanil. In the fall of 2017, he served on a panel for the Clinton Foundation hosted by Johns Hopkins University. And this was focused on examining how the epidemic is impacting groups at the community level. Please join me in welcoming Tom Synan.
Thanks, Josh. Good morning, everybody. Thank you. I like that. That's nice. I wish I was here on a happier topic than the opiate epidemic, but unfortunately, and this is my personal opinion on this part, there is no other social or public health issue that we're facing that is more critical than this issue at the moment in the United States. We are literally losing tens of thousands of Americans because of this epidemic. And I want to have an open and honest discussion today, because in my opinion, what really is going to solve this is having those open and honest discussions. Because I hope that you walk away understanding at least three things, having a better understanding. One, the complexity of this issue and the need for complex solutions. We won't even have time to get into all the complexities, like social issues, economic issues, race issues, the need for sentence reform, all those other, and we haven't even touched on the juvenile system that's overburdened, along with grandparents that are raising kids right now. We won't have an opportunity to do that. And even with that, we won't even touch the surface of the complexity of addiction in itself. Two, I hope that you have a better understanding that this issue is devastating our communities and our individuals. And I want you to have a better understanding of the human cost of this epidemic. But number three, and probably most importantly, I want you to have a better understanding that there is hope, that there are people who survive. There are people who make it through this. They get back into the society, they get jobs, and they get back with their families, so we can never lose the fact that there is hope. Let me explain how I got involved in this issue, because if you don't know where Newtown is and you never got a ticket, which is probably a good thing, if you got a ticket, don't tell me. I'm a chief of a small town. Newtown is a very small town. It's 11 miles east of downtown Cincinnati. I got involved in this after I realized that at the time I had hit 21 years of law enforcement in Newtown. I realized in that 21 years that I had watched an entire family die from drugs. Literally, an entire generation of brothers die. The mother died from abusing prescription pills. The middle brother, not too far from here, was shot and killed by crack cocaine. The oldest brother overdosed on heroin. And the youngest brother, who I thought would live forever, he actually set my personal car on fire. I mean, this kid would get in so much trouble and just somehow he made it. He would literally walk down the street with a beer and a joint, and I'd walk up. His name was Charles, but we called him Chucky. I'm like, Chucky, what are you doing? He's like, Tom, man, you're always messing with me. I go, Chucky, you're walking down the street drinking a beer and smoking a joint. He'd go, okay, you got me. I was like, I thought he would live forever. About 2 weeks before Christmas in 2014, I get a call from at home from one of my officers, and he said, hey, Chief, we got Chucky down here. He overdosed. We Narcaned him. We brought him back. He's down here crying and wants help. He doesn't want to die. At the time, we didn't have the connections with the coalition and all the treatment centers, and I didn't know the good people that I know now, so I didn't know where to turn. But I was determined that we would get him help. So I said, whatever you do, if you need to drive him to treatment, we will pay for it. Whatever we need to do, we need to keep him alive. But the complexity of this addiction is so strong that even someone that wants help, that begs for help, when you give them that opportunity, it's extremely difficult for them to move forward. And this is just my personal opinion too, because I've never been addicted. But I will say, based on what I've seen, it's almost as scary to succeed as it is to fail. Because if I have to go through all that work and somehow I succeed through it, then I got to keep that level forever, which is very difficult. So he refused to go to treatment, and I said, we got to keep him alive for one more night, at least one more night. So we took him to jail. We accomplished our mission and kept him alive for one more night. The next morning, he got out of jail, went home, finished up his heroin, overdosed, and died. And I realized that I had watched an entire family, an entire generation of brothers die. That in itself is complex. But what makes this even more complex is we in Newtown, literally, I can look out the window of my office and see this house where his kids now live, one of the brothers. The oldest brother had a daughter. His oldest daughter had been addicted since the age of 12. Down here in Cincinnati, had been prostituted and has been addicted to heroin, fentanyl, and carfentanil since the age of 12. Actually, people go, well, you're an expert on this. You know how I became an expert on fentanyl and carfentanil? It was her. Because we would talk to her every day. She was one that we didn't expect to live, and thank God she has lived. I was in Chicago back at last May, and I was bragging about her. She's in her early 20s now, and I was talking to everybody, telling them how great of a job she's done, how she's recovered. She's a success story. I come back to find out that she had relapsed. Fortunately, we have all these connections now with the coalition and all these people that we now can put a safety net around people. I'm not saying it's easy. It's not easy. If you ever seen the story on Dominique, there was a reason why I called the Cincinnati Enquirer and had that story written, so that people would understand that it took 30 people and agencies to save one person. Not make her addiction free, but to save the life of one person. And I'm just going to say this now, I just thought of it. It bothers me that it takes that many people, that it takes that many agencies to save someone's life. So she's in her 20s. We got her back into treatment. She's doing good again. She's back on the road to recovery, so that's a good thing. The middle brother, we just arrested over the couple months ago for using heroin that he didn't know had fentanyl in it. He gave it to his 17-year-old girlfriend. She overdosed. What saved their life was because we've worked with the health department in Hamilton County and others, and now we carry Narcan. It was one of my police officers that gave her Narcan and saved her life. The youngest daughter, who's 13 now, we have cast a net around her. Every police officer watches over her. It is not uncommon that if you stop by the police station around 4 o'clock, you will see her and her little friend hanging out at the police department talking to the officers. It is not uncommon for us to go to the house and check on her. But the complexity of this is I, as a police chief, have to answer the questions of a 13-year-old girl of what her father was like. That is how complex this issue is. It doesn't just stop. And here's the thing about this. For every good thing we do, there's always an unattended bad thing that we got to answer the next. Let me give you some perspective on how big this issue is. Because I don't think people realize, because we talk about it, but I don't think people realize it. In 2014, and when I talk about Hamilton County, it's going to include Cincinnati, so it's all the communities in Hamilton County. In 2014, there were 298 overall drug overdoses. In 2015, that number went to 414. In that year, more people died in Hamilton County from drug overdoses than car accidents and homicides combined. In 2016, we saw a slight drop down to 403, but we weren't ready to celebrate because, again, for every good thing, there's usually an unattended bad thing. And one of the things that we've done really well is push out Narcan. But I got to tell you, we're struggling with the overdose numbers now because there is a potential that we put so much Narcan out there that if someone brings somebody back that they're not calling 911. So Jen and the health department, along with the Hamilton County Health Department, Talbot House, and others, are really making an effort to make sure people call 911. One is, from a data standpoint, we need that information, but more from a human side, we have the opportunity to intervene with people with some of the initiatives we've taken, like the quick response teams, or soon will be pre-arrest diversion. So it's important that we have that, we are able to intervene with those people. So we didn't celebrate because we were concerned that those efforts didn't necessarily mean that a drug addiction went down, even though that we're putting all these things into place. And unfortunately, what we thought was right. In 2017, we hit an all-time high in Hamilton County with 529 people that died from drug overdoses. I was just up in Montgomery County yesterday. The mayor from New Orleans came down, and the Dayton mayor invited me up to talk about it. And Montgomery County had 586 people died. So it's not unique to just this area, but Ohio is one of the hard-hit areas. When we talk about what is really driving this and what's really making the biggest impact, we've got to bring up fentanyl. And I'll give you an example of how pervasive fentanyl has become. In 2013, in Hamilton County, there were only 8 fentanyl-related deaths. In other words, when they did an autopsy, they would find fentanyl in the system. There was only 8. In 2014, that went to 94. In 2015, it went to 238. The Hamilton County coroner in 2015 processed 187 items that tested positive for fentanyl. 2016 was 424, and then in 2017 was 1,223 items that tested positive for fentanyl. We process in Hamilton County approximately 10,000 people every year through the Hamilton County Justice Center, the jail, for heroin-related items. That's just here. In the United States, in 2016, 64,000 Americans died from drug overdoses, more than in the Vietnam War. It is now the leading cause of death for the people under the age of 50. This has become such a pervasive problem, not only here, but around the country. When I was talking to the mayor of New Orleans, he's like, look, I don't have a problem like you guys do, but I'm telling you, we're starting to see a rise, and to us, it's an epidemic. And I get what he's saying, because when we started the Heroin Coalition in 2015, we started it calling it an epidemic then. We were dealing with 20 to 25 overdoses a week and 1 to 2 deaths. With the introduction of fentanyl, all of its analogs, and carfentanil, we now, on average, first responders in Hamilton County respond to 50 to 70 overdoses every week, with 4 to 5 people dying on average every week. It is not uncommon to have multiple overdoses. What really changed the game was the introduction of fentanyl. Now, I know in a hospital setting, fentanyl is a good thing, and it's used quite a bit in surgery. Dr. Samarkar talks about it and how easy it is to come back. But here's the thing about these drug dealers. They're not doctors, scientists, or pharmacists. They don't care about the person that they're giving that drug to. And fentanyl has changed the illicit drug game for us, and I don't know if we'll come back from it. It is actually extremely scary to me about fentanyl. I got a call from a news station yesterday, and they're like, hey, there's a new drug. I don't know the name of it, so if someone knows, help me out. Gabatine or Yeah, they called me about that and asked me about that. And they said, what do you think about this? This is the new drug, man. This is the new trend. And I said, well, tell me, the people that overdosed, did they have fentanyl in their system? Well, yeah, that's what they're mixing it with, is fentanyl. It's really the fentanyl that worries me. Yeah, we're seeing a rise in crack cocaine. We're seeing a rise in meth. But what's really killing people is that they're mixing the fentanyl with those drugs. So in West Virginia, they had seen a huge increase in methamphetamine use. But I went back and looked, and almost every single overdose death was related to fentanyl being mixed with it. Again, these drug dealers don't care, and there's a couple reasons why drug dealers are doing it. Number one is they got a better product of meth on the street. They call it ice now. It's more pure. So they were thinking, if I got this more pure meth, this ice, I can push that on the street. I can make just as much money as I can with fentanyl. The other reason they were doing this is because this is their logic. They thought, well, if people are overdosing on fentanyl, then why don't we give them an upper, something that'll keep them awake? Remember, these people aren't doctors, scientists, or pharmacists, because that don't work. So the fentanyl is killing people. So my concern about the drug train is not necessarily that there's a new drug out. If it is a fentanyl or carfentanil related drug, I get worried. If it's another drug, yes, I don't want it. And the problem with it that makes it bad is if they're mixing it with fentanyl and carfentanil, what does that mean? It means it's becoming more widespread. So we talk about there's a question already?
Yeah, where is the carfentanil and fentanyl coming from?
I haven't got to that part yet. I'm kidding. I'm kidding. It's mostly coming from a couple places. One is China is a big part of it, and that's what I went down and testified with the Senate on, is you can literally order this on the mail, in the mail. You can get online and order fentanyl and carfentanil. I do not recommend any of y'all doing it, because it's illegal. But you can actually get online, you can order it. NBC News actually did a story where they're going to order $10,000 worth of fentanyl. And this is how bad it is. The company in China said, we'll insure your package if it gets intercepted. So the problem with the post office is the post office doesn't have a legal right to intervene on your packages. UPS, FedEx will do that. There's logistics things too. What they testified about was that the State Department had to get involved. It had to do a bunch of contracts with other countries, and it was too difficult, the logistics and the money end of it. But here's my thing. Did we not freak out about anthrax? And I'm cool with freaking out about anthrax because I don't want anthrax. I'm cool with that. But we had, I think it was 11 cases of, I'll switch to Ebola. We had 11 cases of Ebola in the United States, and Congress opened up $1 billion, declared it an emergency. Now, cool, I'm afraid of Ebola too. I don't want it. But daggone, we have 64,000 Americans that are dying from this, and yet you can somehow get on the internet, order it from China, and have it mailed to your house. Now, that's not saying that there's not other drug routes that are doing it too. The Mexican cartels are very involved in this. So the normal drug routes become part of that too. So the cartels are also ordering from China, or they'll make it on their own and then ship it up through the normal channels, which a lot of times here in our area, it comes up through Mexico, goes up to Chicago, and starts fanning down to Columbus, Cleveland, Columbus, Cincinnati, then down to northern Kentucky, and Huntington, West Virginia is another place that's been hit really hard. So the issue with fentanyl, all of its analogs, and to tie into your question, what has really made this difficult is it used to be that China would ship over fentanyl, and the United States would declare that certain strain of fentanyl illegal. What they would do is they would change one molecular structure of that fentanyl and make a new fentanyl. They would continue to do that. We've identified 15 different analogs of fentanyl in Hamilton County from the coroner's office. I can tell you that there's much more than that. Hey, Tim. There's much more than that of fentanyl that can be produced and made. The good thing is the DEA went to Congress, and just recently Congress passed a law making it illegal to have any of that fentanyl shipped through here. But when fentanyl hit the street in August of 2016, August 19th through the 27th, I'll never forget it because my birthday's the 28th, and it was not a good week. But we experienced almost close, about 174 to 200 overdoses in 1 week, with 3 people dying in that 1 week. And again, it's because of that we've never been the same. And that is now the 50 to 70 overdoses every single week that we experience. I'm concerned about that. If we don't stop that supply coming in, it's going to be extremely difficult for us to reduce the demand. And I want to say this too, because there's a misconception about people that use these drugs. Let me make this clear. It was not the drug user that asked for fentanyl or carfentanil. It was the drug dealer that put it into their concoction to make it more potent and more addictive. If you do not believe me that an organization like that can make it a demand and people want it, for those of you that are old enough, you ever heard of Beanie Babies or Cabbage Patch Dolls? We didn't need none of that, did we? But somehow we became addicted and obsessed with Beanie Babies and went out and fought people for Beanie Babies. So it's not necessarily the user that did that. And one of the other things that bothers me from a SWAT perspective, it was nothing for me as a team leader on SWAT to do a search warrant. And it was about the 6th, 7th, 8th time we were doing a search warrant on the same user that had sold heroin 7 or 8 times. And here we are doing another search warrant. I get a lot of pushback from people who talk about that user. and it's unreal, and they'll say, I'm upset that that person overdoses 4 or 5, 6, 7 times. What about that dealer that deals 6, 7, 8 times? Why aren't people upset with them? But let me add some complexity to this. Because I actually wrote letters to the state legislators asking that we increase penalties for drug dealers who deal in fentanyl and carfentanil. Now, I got pushback from the state on a couple of things. Tom, the jail's too crowded, there's not enough money, we're not going to increase penalties, we're not putting people in jail anymore. I was like, daggone, I'm a cop and I thought we put people in jail. That didn't work. Then I got pushback over here who said, wait a minute, Tom, you don't understand. You've never seen the studies that jail doesn't stop drug dealing. What about the crack epidemic? And I was kind of like, well, I went through the crack epidemic. One of the brothers was shot and killed buying crack cocaine. And they're right. It didn't stop anything, did it? So it gets to the complexity of now we got to start thinking about sentence reform. And is jail the proper place for either one of these? And I'm going to be honest with you here. I don't know. For the first time in my career, I don't know, because I spent 25 years putting people in jail, and now I've seen the studies, I've lived it firsthand, and now I'm one of the people who stands up as a cop and say, you know what, we can't arrest our way out of this. I'm convinced of that. But we need help from that user side. We need to start treating addiction as the medical, mental health, chronic condition it is. We also need to learn that we cannot punish addiction out of somebody. Now, I get some of that pushback. I understand it. And people say, wait a minute, it's not fair that you Narcan that user and they don't have a penalty. If I was drunk on the side of the road, you would take me to jail. My response is, have we ever cured alcoholism? No. We're not going to cure addiction by putting people in jail. So then we have to start having conversations. Who should be in jail? Who shouldn't be in jail? And what is the purpose of jail? If the purpose of jail is trying to rehabilitate somebody, whether it is from addiction, and I got to tell you, here's the other part of this I just thought of that I struggle with, is guess how we as cops try to keep people alive? Take them to jail. If we can't get them into a treatment center, guess what we do? We try to keep them alive for at least one more night. I accomplished my mission. I kept the person alive for one more night. I didn't keep him alive for the rest of his life. So when we're talking about people in the jail system, if they're just sitting there festering, then that addiction is doing nothing more than infecting the brain more. So then let's talk about the dealer, because that's even more complex, because there's social issues around that. What's the economics of that? What environment did that kid grow up in? What is the purpose of them doing that? I've been pretty vocal. I was pretty upset when the president made the comment that we need to give the death penalty to dealers. Look, I'm all cool giving a tough penalty on dealers, but then we better start defining who's a drug dealer and who's not. Because there is evidence that shows, now it's dropping, but when it first started, it was the overprescribing of medications like Oxycontin and oxycodone that really helped fester this and push it out to where it is. So what's the difference in the dealer? That 18-year-old kid gives you a free sample. I've walked in the doctor's office, got free samples of medication. That 18-year-old kid marks his package so that you know where to come back. That distributing company marks on there the name of the company so you know where to come back. And what did both of them do it for? What was the ultimate reason they both did it for? Money. So tell me, who's the drug dealer and who's not? So we as a society better start defining some of these things and trying to figure this out, because if we don't, guess what it adds? Complexity to the issue. And it's funny because as a cop, I get pushed back on two things that I never thought I would. Number one is being tough on the drug dealer, which now I understand it because I listen to other people and I kind of see their side of it. The other one, and Tim will vouch to this, get pushed back for giving people Narcan. It is stunning to me. I believe, and we'll have an open and honest discussion here. Like I said, I'm cool with getting in the weeds. I'm cool with everybody's opinion. I believe there's validity in everyone's opinion on this issue except for one. And that is that it's okay to just let people die. There is no other segment of society that we openly discuss letting them die than that person that's addicted to drugs. What makes them different than anybody else? Because they committed a felony? because using drugs is a crime, right? Because somehow we think as a society we can control this brain. Somehow we think that somehow this brain is not attached to our body and that it can't have trauma and can't be bruised. I gave a talk with a psychiatrist. He's down at Children's Hospital. He's like the coolest dude ever. And he had the best thing to understand addiction. He looked at everybody and said, okay, anyone that's ever tried to diet, raise your hand. And everybody raised their hand. He goes, okay, everyone that reached your weight, the goal weight that you had and kept it off, put your hand down. No one put their hand down. And he's like, what's wrong with y'all? You couldn't choose an apple over a Big Mac? What's wrong with y'all? Multiply that by thousands when we're talking about addiction, especially from oxycodone, heroin, fentanyl, carfentanil. Fentanyl and carfentanil anywhere from 50 to 10,000 times more powerful than the opiate of heroin, which turns into the body, correct me if I'm wrong, to morphine. So we pushed out Narcan. And my thing is, I don't get asked to let anyone else die. I've been on car accidents where it's the person's fourth or fifth DUI, OVI, whatever you want to call it. Not once did society ask me to let them die. I actually had a call 12 times a person tried to commit suicide. Not once did society ask me to let them die. As a matter of fact, they said you should risk your life to save theirs. But somehow this group, I'm asked to let die. And when people tell me that, usually my response is, you've never stood over the body of someone who's died. Because if you had, you would stand there next to a mother, father, brother, son, sister, or daughter. And realize that even if you don't have compassion for that person that died, you must have compassion for that family who suffered just as much and just as long and will continue to suffer longer because of that addiction. And what makes this addiction so much more difficult than any other are the sheer numbers and the immediacy of death. That's what's been put on the street. I will discuss anything. I will listen to anybody. I will believe that you're valid on just about everything except for letting people die. That is one discussion I will not have. And Tim's here and he can give me an exact number, but to give you an idea of how many lives we saved, I think Cincinnati Fire, if I'm not mistaken, they usually on average about 8,000 units a year. And what did we do here in Hamilton County? That is about 11,000 chances we had to save somebody's life. Of all the things that I'm most proud, I'm proud of being part of the coalition, but I'm really proud that I worked with Tim, and Tim's been a great leader on that to push out that Narcan, because we literally can see the lives saved. Where we're at now and what we're struggling with and one of the hurdles we're trying to overcome, and I think we're getting there, is how do we connect that person from the street to longer term care? And when we talk about treatment, then we got to start, I'm not in treatment, some of these people are, but here's my thought on this treatment, is we got to start redefining what treatment is. And this is just my opinion. Treatment needs to be longer term continual care, because again, if we're going to treat that chronic condition, that medical condition, then we must treat it like we do everything else, like heart disease, COPD, mental illness. If we don't, then we're not going to fix this. We're going to fail if we don't look at it that way. And we got to talk about treatment, and we got to have a little bit different standards, because I was just talking to somebody the other day, I had breakfast with them, and we were talking about, you know what, if you had Parkinson's and you went to your doctor and you weren't following everything perfectly or the medication wasn't working, your doctor wouldn't say, oh, you failed, get out of here. But what do we do for the person that is in drug treatment, that user? If that user fails, guess what? You're kicked out. We don't do it with any other chronic condition. Why are we doing it to this group? But part of this has to be a change in our mentality, a change in how we view this addiction. So we're working on the treatment end. But then the other part of this is we're going to have longer term care. We got to connect from that front end. We got to find that middle ground where we put people into treatment, longer term care. It's got to be that continual care, which then has got to be re-entry, cognitive behavioral skills. We got to have job training on the back end. We've got to be able to have support for the child care, for the people who need child care. Because here's the thing, and I'll go to those people who think about the finances of this. I'll go into your mindset, because that's legitimate. The United States spends anywhere from $74 billion to $503 billion on this epidemic. Gone. Lost on the front end. we get zero return because of the way we're handling this. Just think if we were able to treat it like the other chronic conditions. Just think if we could get people into recovery and get them back into the workforce, get them back into jobs, back into their families, and started paying taxes. Guess what we do? We recoup our money. So that's the ultimate goal that we got to get to. So let me finish up with a couple things. I have hope. I honestly, for the first time since we started this, have hope. And I think this year we're close. I know there's some things in the works, and if the one thing gets in and clicks, it's going to make a significant difference in how we view and deal with addiction in this area. There's a couple initiatives that the coalition is working on that I think if we can get them in and click them in, then I think we actually shift this epidemic and we actually make a dent in it. But they're tough conversations and they're difficult conversations. And I've been the one that's been on the forefront of this, and I know not everybody's happy about this, but I feel very strongly about this. We have to look at involuntary commitment as one of those pieces that goes in part of this solution to this epidemic. Because only 1 out of 5 Americans volunteer for treatment. In the city of Cincinnati, it was a few years ago, 69.7% of the people that the city of Cincinnati Narcan, we walked away from because they refused treatment and refused to go to the hospital. Now from a liability end, I'm worried about this because we know fentanyl is pretty much in everyone that overdoses. So I'm not a doctor. Dr. Ryan will be here. So Dr. Ryan, when I first started this, everyone's like, oh man, how do you know all this stuff? Well, I talked to people like Dr. Ryan, but he used these big words. I'm like, Dr. Ryan. He was explaining how Narcan worked. I'm like, Dr. Ryan, you got to do this little stick figure thing. And he's like, okay, Tom, here it is. Now, you know the the top of the stick figure, there's like this round thing? I'm like, uh-huh, what is that? He's like, that's the head. You know what's inside there? It's the brain. I'm like, slow down, Dr. Ryan, I'm writing this down. So he was explaining Narcan to me, and basically, and Dr. Ryan and all the other doctors can help me out, but this was just the generic version, is that opiate molecule sits on the brainstem. What Narcan does is basically knocks it off and sits on there and replaces that, so that molecule can't reattach. But the problem is that Narcan lasts about 45 minutes to 90 minutes. It's funny because I listen to doctors and one say 40, 30, 90. So I'm going to go 45 minutes to 90 minutes. However, fentanyl stays in the system for 1, 2, 3 hours. Carfentanil, I don't think there's any knowledge of because it's not intended for human use. As a matter of fact, carfentanil, 2 grains of salt, is generally what they use to knock out an elephant. So we're not even supposed to be consuming this. So my concern when we Narcan somebody and walk away, guess what we're walking away from? Number one, they're highly likely to re-overdose on the same dose that they just overdosed on, if that makes any sense. Because a lot of people think that when you Narcan somebody, they're just jumping up and going, hey man, thanks a lot, I feel better, let me go get some more. They're not. Well, how many kits of Narcan did we use, Tim, you said? 11,000? 11,000. So there's also this misconception that when people wake up, somehow first responders are getting their butts kicked all over the place. 11,000 doses, not a single report of a first responder injured or even in some type of an assault. So we got to get over that myth, and we got to understand that when we're reviving someone from Narcan, we cannot just walk away from them. We are walking away from somebody that we know is addictive, that is still under the influence of a drug. So to me, civil commitment has to be part of this. And I know there's controversy, but the studies kind of negate themselves. It's cool being around doctors and scientists because they're all these data people. And for once, I was able to go, here's a study, which one's right? And they're like, they negate each other. Yes, I win. But I just saw an article in Florida. There's 33 states that have involuntary commitment. Just got an article from Florida. Jacksonville is a big area that's been doing it. They had 400 people that they civilly committed. 2/3 of those people completed treatment. Let me say that again, because there's a key word to this, completed treatment. Not criminal commitment, but civil commitment, because it does no good if we're going to charge them with the crime, because then they can't get back and get a job. We just put them back in another position to where they're going to be struggling. And that's what I ask is, how much of this is us? I hear people say Narcan enables people. How much are we as a society enabling this addiction and this epidemic? So we got to make sure they don't have criminal charges. That 2/3 are people who completed it. What we measure now a lot of times is how many people we can even refer to treatment or get in the door. So it's got to be both. We got to have an efficient system that allows people to get in quicker who voluntarily want to go, or one that a doctor can refer to, or one that a quick response team can get to, or pre-arrest diversion can get to. What it is tying into is we're coming up with a complex answer to deal with a complex question. But that civil commitment's got to be part of it. So I hope that we're making a difference. I honestly believe that this year some things are going to click that will make a big difference. And I know it seems overwhelming. I know it seems scary. I know it seems like there's too many. But let me tell you about one of my favorite stories, and you hear it a lot in the treatment. I never heard it before until I got involved in the heroin issue, and that's the starfish parable. It's about this young boy who's walking down the beach and where thousands of starfish have washed up. He knows that if he doesn't get them back into the water, they're all going to die. So he starts walking down the beach, he picks up a starfish, throws it in the ocean. Picks up another, throws it in the ocean. Picks up another, and throws it in the ocean. An old man seeing this walks up to the boy and says, "Young man, what are you doing? You're wasting your time. There's too many. You'll never make a difference." The young boy picks up a starfish, throws it in the ocean, looks at him and goes, "I made a difference in that one." That's kind of how we got to look at this. Let me end with this quote. I wrote it down so I wouldn't forget it. "I exist not to be loved and admired, but myself to act and love. It is not the duties of those around to help me, but I am duty-bound to look after the world and after man." My question to you, who among you is duty-bound? Thank you.